Hello everyone, I'm Dr. Akash Ganguly, and today the topic of my presentation is going to be trigeminal neuralgia. I'm going to discuss this topic under the following subheadings. First, I will talk about the definition of this trigeminal neuralgia, the anatomy of the trigeminal nerve. I will talk about the types, the etiology or causes of this disorder, briefly describe some of the pathophysiologies that have been associated with this disorder, a brief history about this disorder that has been described since a long time and known to us for a long time, the clinical presentation, its risk factors, diagnostic criteria. Before going to the diagnostic criteria, I will try to talk about the inciting factors, the precipitating factors, and then I will talk about the prevalence, then the diagnostic criteria, the differential diagnosis, some of the investigations, then finally the management. That can include the medical management or the surgical management. Perhaps the screen looks a little bit messy. These are some notes that I prepared well before, but I hope I can explain the topic so that you people can understand. First of all, I will come to the definition of this trigeminal neuralgia. According to the International Classification of Headache Disorders, ICHD-3, it is a disorder that is characterized by recurrent, unilateral, brief, electric shock-like pain that is abrupt in onset and termination and is then limited to the distribution of one or more nerves, one or more divisions of the trigeminal nerve, and triggered by an innocuous stimuli. This is actually a sudden, usually unilateral, severe, brief, stabbing, lancinating, recurring pain that is limited to the distribution of one or more branches, as I have described earlier. So next I'll come to the anatomy of the trigeminal nerve. This diagram you can see, this is showing the Meckel's cave here, where the trigeminal ganglion or the Gasserian ganglion is resting. To my left side you can find this. Now we'll shift our focus. I'm going to briefly tell you about the anatomy. Like, it is the largest cranial nerve with both sensory and motor components. Vagus is the longest nerve, whereas trigeminal is the largest cranial nerve. It provides both sensory and motor supply, and if we talk about the sensory nerve supply, it gives its sensory branches to the face, nasal cavity, oral cavity, including the teeth. It gives proprioception to the periodontal ligament fibers. However, the motor supply is given to the tensor veli palatini, tensor tympani, anterior belly of digastric, muscles of mastication. Coming to the branches, we have first the ophthalmic, the maxillary and mandibular. Well, this nerve can be divided into various anatomical segments by its course from the brainstem, the cistern, then the Meckel's cave, ganglionic, and finally the peripheral divisions, that is the ophthalmic, maxillary and mandibular. Now this trigeminal ganglion or Gasserian ganglion, as we can see here, it is located in the Meckel's cave, and it is a recess between the two layers of dura mater in the posteromedial portion of the middle cranial fossa. It can develop the symptoms of trigeminal neuralgia. Now, arachnoid matter from the posterior cranial fossa can extend into the Meckel's cave and continue along the rootlets of trigeminal nerve to as far as the trigeminal ganglion. Now we'll talk about the branches of these three divisions. Like in ophthalmic, we have frontal, lacrimal, and nasociliary. In frontal, we have the supraorbital and supratrochlear branches. In the nasociliary, we have long ciliary, anterior and posterior ethmoidal nerve to the ciliary ganglion, infratrochlear. We can remember with the mnemonic Alice. Now if we go to the maxillary division, we have these following branches, that is, and we can remember this mnemonic, that is MGPIZ. M for meningeal, G for ganglionic, P is posterior superior alveolar, infraorbital and zygomatic. Now these also have sub branches. In ganglionic, we can remember the branches by GLNN, that is greater palatine, lesser palatine, nasopalatine and nasal branches. In infraorbital, we have the other two branches like anterior superior and middle superior, whereas posterior superior is in itself an individual branch coming out from the maxillary division. In zygomatic, we have zygomaticofacial and zygomaticotemporal. Now coming to the mandibular division, we have the nervus spinosus. The motor division divides into anterior and posterior division. In the anterior division, we have all the muscles of mastication, like the nerve to the lateral pterygoid, the masseteric, the deep temporal and buccal. In the posterior division, we have auriculotemporal, articular to the TMJ, secretomotor to the parotid, lingual nerve, inferior alveolar. In inferior alveolar, we have the nerve to mylohyoid and the mental nerve. After the anatomy, we will go on to the etiology or the causes of trigeminal neuralgia. In this, we have primary, which may be idiopathic. In secondary, we have included tumors, which may be acoustic neuroma, cerebellopontine angle tumors, schwannoma, pituitary gland tumors. In vascular, we have the pulsatile compression of adjacent vessels. In inflammatory, we have multiple sclerosis. In post-traumatic, we have viral, accidental, dental trauma, sinus trauma. Now we will talk about pathophysiology. There are some theories involved with this, but broadly we will discuss it in three things, like three subheadings. Like first, there is compression of the trigeminal nerve, the trigeminal nerve rootlets. Then another cause may be the primary demyelinating diseases. The third is the sensitization and dysfunction of the pain related circuits. The first subheading is the major thing to be discussed here, that is the compression of trigeminal nerve root. I have tried to talk about the pathophysiology based on an article by a review article by Chen et al. In 2022, that was published in the International Journal of Molecular Sciences, if I am not wrong. In the first subheading, that is the compression of the trigeminal nerve root, we can find that at the junction of the peripheral trigeminal nerve or the root of the nerve, there is focal neurovascular compression, that is, there is a direct contact of the vessel over the nerve, the trigeminal nerve or the ganglion. Now this is found within the Meckel's cave, as we can see here in this diagram to the left of the screen. The Meckel's cave, this is actually this Meckel's cave is having the trigeminal ganglion, and this is the most common cause, this compression of neurovascular compression, and this is due to the direct contact with the arteries or veins on the trigeminal nerve rootlets. Other causes may be space occupying lesions like any cyst or tumors. There may be tumors like vestibular schwannoma, meningioma, aneurysms or AV malformation. Now when we come to now it is seen that the cascade of reactions that may follow are not well understood. But if we see the histology, it is seen that the trigeminal nerve compression is associated with two things: myelin erosion and the disintegration from inflammation at the nerve indentation area. So the pathway of abnormality is related to the pathological demyelination as well as the remyelination of the injured nerve. So it is seen that there is a pathological increase in the metabolic demand for the myelin sheath growth as well as maintenance, which is found in chronic nerve compression. There is evidence of axonal dystrophy and Schwann cell damage. And if we go to the downstream effects, the trigeminal nerve symptoms come through the dysregulation of the voltage gated sodium channels. In biopsy, while doing biopsy, it was found that there is an upregulation of sodium voltage gated sodium channels NAV 1.3 and 1.1 upregulation, whereas there was a downregulation of sodium gated voltage gated sodium channels 1.7. What happens is that when there is upregulation of sodium voltage gated sodium channels 1.3, there is neuropathic pain conduction, and this is a distinct mechanism of by which we have the major contribution to enhance sensitivity and ectopic impulse generation. Whereas whenever there is downregulation of the NAV 1.7, we have fast inactivation as well as slow recovery, and this is actually responsible, this downregulation of NAV 1.7 and upregulation of NAV 1.3, in increasing the neuronal excitability, and there is an impaired normal nociceptive response. There is also, it is seen that there is an upregulation of NAV 1.1 which leads to excitability of the trigeminal nerve. Now Gupta et al. In his study found that there was significant apoptosis as well as persistent downregulation of the myelin associated glycoprotein in the Schwann cells following chronic nerve compression. So he found in a study that when there was chronic nerve compression injury, there was apoptosis as well as persistent downregulation of the myelin associated glycoprotein in the Schwann cells. There was ectopic generation of action potentials which was prolonged after discharges in the demyelinated neurons. Devor et al. Gave the ignition hypothesis. This is the pathophysiological explanation for the clinical characteristics of the trigeminal nerve, where we find that there is demyelination as well as hyperexcitability of the trigeminal neurons following the nerve compression. So after the nerve compression, two things are happening, that is demyelination as well as hyperexcitability. This form the backbone of the ignition hypothesis given by Devor et al. So during a paroxysmal attack, we find that normal innocuous stimuli, this normal innocuous stimuli can give rise to amplified trigeminal afferent inputs by means of prolonged discharges plus ephaptic crosstalks between demyelinated axons. These are some terms which can be dealt in the neurosurgical level but not important at this level. You can, however, search about it. Now the attack could subside when the offending stimulus is removed or if the triggering threshold is increased. Now we will go with the second subheading, that is primary demyelinating diseases. When we can think about when we talk about this, we can think about think about multiple sclerosis or the T cell mediated T cell mediated immunity that is acting in this disorder. So this can lead to the trigeminal neuralgia symptoms, and patients with multiple sclerosis have increased risk of developing this trigeminal neuralgia than the general population. One more important thing is that there is intrapontine demyelination along the trigeminal afferents and trigeminal nucleus associated with the trigeminal neuralgia symptoms. Also, the second order sensory neurons are affected. When we come to the third subheading, that is the sensitization and dysfunction of central pain related circuits, we will talk about central sensitization. Well, it is a process by which the nociceptive receptors or the nociceptive systems become hyper excitable. And in this trigeminal neuralgia patient, there is amplified nociceptor signal transmission. So Obermann et al., he gave a pain-related evoked potential which was significantly augmented in all trigeminal divisions in both symptomatic as well as non-symptomatic sites. This suggests that sensitization in the trigeminal pathway as well as supraspinal pain modulating circuits is important part of trigeminal neuralgia pathophysiology. So the one more thing that is important here is that by neuroimaging study, it was found that when there was pain in the pain attacks in trigeminal neuralgia patients, it was found that in trigeminal nuclei as well as thalamus and somatosensory cortices, an increased activity was present which was actually related to the pain related sensory processing. Now we'll talk about the types. In types, we can broadly divide it into 5 types, 5 or 6 types. Before talking about this types, we will just briefly describe the history. Well, in 1677, John Locke first gave the description about this disorder. In 1756, we had Nicolas André giving the tic douloureux because of the symptom of involuntary spasms that occur in these type of patients. In 1773, we had Fothergill, who gave the name Fothergill's disease, where we find that it is where he gave the description of paroxysmal unilateral facial pain, which is evoked by eating, speaking, or even washing the face. And in the 11th century, we have Jujani et al., who gave this, who was an Arab physician who described this disorder as an unilateral facial pain causing spasm and anxiety. Oppenheim was another person who highlighted the association between trigeminal neuralgia and multiple sclerosis. However, the mechanism has become clear now, as I've discussed in the primary demyelinating disorders pathophysiology subheading. During 1950 to 1960, Gardner and McClose promoted the neurovascular compression theory, which was actually a pathfinder for the treatment, for the surgical management, where we find that Dandy and Janetta gave the microvascular decompression of the nerve. This person, I'm sorry I can't pronounce it perfectly, Berguignan, he gave the phenytoin. In 1953, Winter Schindler discovered the carbamazepine, and the marketing started in 1962. Now I'll talk about the types. First, we have the typical trigeminal neuralgia. Second, we have the atypical. Third, pre-trigeminal neuralgia. Third, multiple sclerosis associated. Fourth is the secondary or tumor related. Fifth is the secondary or tumor related. Sixth is the trigeminal neuropathy or post-traumatic trigeminal neuralgia. Now we'll talk about the clinical presentation. It is a sudden sharp shooting, lancinating, unilateral paroxysmal intermittent shock-like pain. And the pain episodes may last from seconds up to several minutes, described by patient as electric shock feeling. The sensation may occur frequently per day, up to hundreds of times over weeks and months, and then suddenly stop with pain-free periods in between. It may present infrequently with periods of remission, but this disorder may possibly last for years. According to NICE guidelines in 2017, we have that it was given that pain occurs usually unilaterally and very rarely crosses the midline. Even if it crosses the midline, in 3% cases, it has been found to be bilateral. Now the trigger zones for this first division is over the supraorbital ridge. In the second is the skin of upper lip, ala, nasi, cheek and gums. In the third division, we have the trigger zones as lower lip, teeth, gums, tongue. So going forward, we find that during the attack we may have hands over the affected area, which may stop activities, or hold or rub the face, which may redden, or the eyes may water until the attack subsides. Pain attack is accompanied by tick-like cramps. That is why the name tic douloureux. The patient suffer from depression, isolation. There may be partial numbness, hypoesthesia, anesthesia, and due to hyperexcitable discharges. This may occur. Now coming to the risk factors, in sex we find that females are more pronounced to have this disorder in age. According to Kalosik et al. And NICE guidelines 2017, over 80 years males have higher incidence, that is 45 per 1 lakh. Though it is prominent in all age groups above 50 years, and it is, according to White et al., it is given that it is rare to find this disorder in patients younger than 40. However, exceptions always exist. It may be present in younger patients who suffer from trigeminal. Multiple sclerosis may be present in younger patients. So the initiating factors can be precipitated by the trigger areas or by touching the areas of face. So patients try to avoid touching these areas or doing the activities that trigger these. Some of these activities include shaving, hand wash, mouth washing, applying makeup, face creams, brushing of teeth, speaking, smiling, eating, face washing, then we have swallowing, yawning, and then exposure to cold breeze, then many other things like touching that part of the face. Now coming to the prevalence, according to D. Toledo et al. In 2016, he gave a systematic review. In this, he said that the range of trigeminal neuralgia prevalence is about 0.03 to 0.3%, and women were affected more with an age range of 37 to 67 years. NICE guidelines in 2017 said that UK annual incidence is more. The clinical diagnosis, then we will go on to clinical diagnosis. Pain history is very important to know the site of pain, how it progresses, to get an appropriate idea about trigeminal neuralgia. So about this, we have the Socrates assessment tool. Each alphabet has a significance. For example, S stands for site, to know whether the patient can localize the site. Then O stands for onset, whether it is sudden or gradual, whether it is during the course of day, night, or spontaneous. Characteristics of the pain. C stands for characteristic, like whether it is sharp, stabbing, lancinating, or dull. Then radiation, whether it has radiated to other areas. A stands for associated signs and symptoms. Timing and duration. T for timing and duration, whether it is for seconds, minutes, or hours. Well, it is found that it is generally between seconds to fraction of seconds or 2 minutes, or there is any exacerbating or relieving factors. Or severity. Finally, S for severity, how severe is the pain in a scale of 1 to 10. So the visual analog scale can be used. Now the classical symptoms are severe stabbing, lancinating pain, we have already discussed. According to ICHD, that is the International Classification of Headache Disorders, there are certain criteria, and it is said that at least 3 criteria should be fulfilled to call it a trigeminal neuralgia. For example, first, it should be occurring in one or more divisions with no radiation beyond the trigeminal nerve distribution, that was there in the definition. Then pain should have at least like this is the basic theory. Now out of the following points that I am going to discuss now, these 3 theories, out of these criterias, 3 of them should be fulfilled. Like it should be recurring in paroxysmal attacks, severe intensity may be there, electric shock like pain, it should be precipitated by innocuous stimuli to the affected side of face. Coming to the investigations, like thorough pain history and clinical evaluation should be done. The cranial nerve should be examined to know about whether any tumor or multiple sclerosis is giving rise to this disorder. Then we should take help from radiographs like IOPA, OPG. OPG to see the TMJ condition, IOPS to see if there is any caries or not, CT to see maxillary sinus, then MRI to see if it is due to any neurovascular compression, or to exclude any posterior cranial fossa lesions, whether it is idiopathic. Because in idiopathic cases it is found that there is normal neurological findings as well as the MRI examination is also normal, so there is difficulty with treatment planning. Now we'll go on forward. It is found that there may be an aberrant loop of blood vessel at the root end zone, or this area of the nerve. So the most common cause, which is neurovascular compression in 60 to 90% of the cases. So Meany et al. Gave specific parameters using which the nerve or vein the vessel could be reconstructed using the thin slices of this MRI, and this is called MRTA, that is magnetic resonance tomographic angiography. Now we will go on to the management. Before the management, I'll mention some differential diagnosis, like we can call it cluster headache. We can get confused with cluster headache, migraine, sinusitis, any TMJ pathology, any post-herpetic neuralgia, something like that. But these can be differentiated very easily. Like in migraine, we can find that there is photophobia or phonophobia. Now if we see this management, we are going to talk about the medical and surgical management. Before talking about the medical management, I am going to discuss the surgical things. Then I will briefly talk about medical and surgical techniques. In surgical management, we have to interrupt the pain pathways between the center and the periphery. So this can be done extracranially or intracranially. In intracranially, we have this mnemonic ARM square I, that is alcohol blockade at Gasserian ganglion, RFTC at the Gasserian ganglion, retrogasserian rhizotomy, medullary tractotomy, midbrain tractotomy, intracranial nerve decompression, Janeta's approach or Dandy's approach. In extracranial approach, we have ANEGS, ECS, like alcohol blockade in the peripheral nerve, then electrosurgery, cryosurgery, selective radiofrequency thermocoagulation. Other neurectomies are peripheral neurectomies, like which can be done on the supraorbital aspect, infraorbital, lingual, inferior with the Ginwala's technique, physiologic inhibition of pain by transcutaneous nerve stimulation, acupuncture. Psychological approach are biofeedback, psychiatric counseling, hypnosis. Now if we go to the medical aspect, in the medical management, we have this drugs that can be used, like gabapentin with an initial dose of 300 milligram with maximum dose 1800, baclofen 5 maximum dose 80, clonazepam 0.54, lamotrigine 50 300 to 500, and then oxcarbazepine 300. It's a very useful drug. 1200 is the maximum dose. Topiramate 50. Then we go on to 200 milligram. Carbamazepine 100 BD, and this can be given to a maximum dose of 1200 to 2400. Well, carbamazepine, it is a very important drug, and it is actually an anticonvulsant. It is the first line of drug for the treatment of the patients. It does not respond to the analgesics. Including when the patient does not respond to analgesics including opiates, these are used. The attack of pain in these is probably due to the pathologically hyperexcitable sensory trigeminal neuralgias. It can slowly discontinue, like if we now we have to see this, that if we slowly discontinue the medication when the patient is asymptomatic, it can be done to see if the patient in pain, the patient is going through pain-free remission period or not. So it can be used both for diagnostic as well as therapeutic. This person, Bourgoignon, in 1942 found out phenytoin, which was effective in controlling attacks of phenytoin. Carbamazepine is the standard first line of drug for trigeminal neuralgia. Well, it is highly specific in relieving the pain of trigeminal neuralgia, not any other type of facial pain. It is given 100 TDS introduced and then titrated over 1 to 5 weeks. It helps in stabilization of neuronal membrane by blocking the sodium channels. So from current guidelines such as the NICE guidelines, we find that the advantage is if there is no sinister or red flag symptoms are evident, the carbamazepine is not contraindicated, and it is given in 100 mg twice daily dosage, titrated in increments of 100 to 200 every 2 weeks until pain has been relieved. The 1600 maximum dose can be given. Pain in remission dosage rendered to lowest possible maintenance level, discontinued until further episode occurs. We have to go for full blood count and LFT. The side effects include visual blurring, dizziness, somnolence, redness, ataxia, and rare side effects are hepatic dysfunction, thrombocytopenia, aplastic anemia. When this drug is contraindicated, we have to go for clonazepam 1.5 mg per day. The tablet oxcarbazepine can also be given with a dose of 1200 per day. Side effects are hyponatremia, double vision. Gabapentin has an effective role in solving neuropathic pain management. An RCT was given that stated that it is important in pain control, causing fewer side effects. The combination of gabapentin and ropivacaine is used when there is injury to the trigger points. Baclofen, another important drug, is generally accompanied to used in trigeminal neuralgia patients with multiple sclerosis. Side effects are sedation and loss of muscular tone. Its abrupt discontinuation can cause hallucinations and seizures as side effects. Lamotrigine, it is used when the carbamazepine is not tolerated well. Now, botulinum toxin A, which is a lot used in various purposes like as fillers, in aesthetic purposes, it is also used here. It gives 60 to 80% reduction in the pain intensity and frequency. Another new advancement is 8% lidocaine spray with IV infusion of phosphenatoin has given temporary relief for patients suffering from severe pain. Coming to the surgical management, well, microvascular decompression, that was originally, the theory was given by Dandy in 1925. Milclose and Gardner and Milclose in 1959, they gave the vascular compression theory by the nerves. This was refined by Janetta et al. In 1967. The surgical target was actually the trigeminal nerve, the pons junction. So in this diagram you can see that it is through the craniotomy, suboccipital craniotomy, access is gained to the posterior cranial fossa. On entering this, CSF is aspirated. Gently we retract the cerebellum. And on retracting the cerebellum, we can find that this vessel, this may be superior cerebellar artery, that may be compressing the root end zone. So this may be found in most of the cases, but as variation we may also find anterior inferior cerebellar artery or superior petrosal vein, which may cause the compression. So once the vessel is freed, a sheet of Teflon is placed to keep the nerve and vessel apart. Utmost care is taken to avoid any injury to the ears, or like not ears actually, to the hearing loss, to prevent any hearing loss some other complications are also present. Like, since it is a surgery, there may be stroke, CVA, some 7th and 8th nerve injury, since it is very close to the cerebellopontine angle. Then in pediatric patients it is found in some cases also death may occur. So it is to be, the surgeon has to be very careful. Now in pediatric cases, vein compression is more than arterial compression. In retrospective study, the complications I have just described were given as follows: cerebellar injury 0.45%, 8th cranial nerve injury 0.8%, CSF leak 1.85%. Then gamma knife radiosurgery. Radiation may block the conduction of excessive sensory information. This procedure was done under LA with or without sedation. The patient was kept supine. Actually, this is neither a surgery, neither any knife is used. The gamma knife, it is a misnomer. It is actually under LA, the stereotactic head is secured to the patient's head. The MRI is performed to locate the trigeminal nerve, and gamma knife, which is consisting of 201 intercepting beams of gamma ray, it is thrown, which has a dose of about 70 to 100 grays. It is thrown at the site. It is targeted at the site of root and zone, and then we find the relief of symptoms in a very short duration of time. Another technique is the percutaneous, that is through the skin, balloon compression, which was described by Mullen in 1980. It relieves the trigeminal neuralgia pain by injuring the large myelinated fibers in sensory trigger, that is responsible in sensory trigger. So under short general anesthesia with fluoroscopic control, a 14 gauge cannula is inserted into the foramen ovale, and catheter is then advanced through the needle. The balloon is inflated with up to 1.3 to 1.6 atmospheric pressure and inflated with 0.5 to 1 ml of contrast dye till it occupies the Meckel's cave. Radiographic confirmation whether the position is fine or not. The subjective numbness resolves in 4 weeks. Then we go about another technique, that is the radiofrequency thermocoagulation. Well, the failure to control the spread of this alcohol in gangliolysis has given rise to this procedure. In this, thermocoagulation of the Gasserian ganglion that is resting in the Meckel's cave is done. It is done at a temperature of 65 degrees Celsius. It selectively ablates the A delta and C fibers. Short intermittent GA is done with fluoroscopic control, and obviously it is radiographically guided. The patient is awake with the correct position of the needle is taken, and the radiofrequency needle is with stylet is inserted into the Meckel's cave and through the foramen ovale, and using bony landmarks there is transient bradycardia, but the needle position is confirmed by fluoroscopy and radiograph. Then patient is awakened and stimulation of the nerve root is tested. Another technique is glycerol rhizotomy. It is done under LA with sedation. Small dose of sterile glycerol and 1.1 to 0.4 ml is used based on the number of divisions. This allows glycerol to reach the intended root. The complications are local hematoma, cranial nerve palsies, reactivation of the herpes labialis, permanent masseter weakness. Now, peripheral nerve procedures include infraorbital neurectomy. There may be pain relief in 15 to 24 months in this procedure. So what is done? Access is gained through the maxillary vestibular approach. Infraorbital foramen is identified. The nerve is released from the foramen by raising the periosteum around it. Then care is taken so that no pull is there to the trunk of nerve in the canal. Now the reeling is done. Reeling of nerve is a common practice, but here the sectioning is done. So nerve sectioning is done using diathermy so that we get a bloodless or hemostatic feed. Now infraorbital nerve canal can be obturated with bone wax. Coming to inferior alveolar nerve or the mental nerve neurectomy, it was given by Ali FM et al. In rural setups, and it is an effective option for elderly patients who are reluctant for neurosurgical intervention, or also when the expertise is not available to undergo these procedures. Then we also have another technique, that is the inferior alveolar neurectomy or via the Jinwala's approach. It is done under GA. Access is gained to the medial aspect of ramus, And using inverted Y-shaped incision, mucoperiosteal flap is raised along anterior aspect of ramus. The tendon of temporalis and medial pterygoid is raised off the bone, and access is gained to the lingula. The nerve bundle is clamped and cut below the clamp by electrocoagulation to achieve hemostasis. The bundle is clamped and sectioned to avulse the nerve bundle from the canal. Coming to cryotherapy. Cryotherapy is performed by surgical exposure of the nerve endings with a temperature of -50 to -70 degrees Celsius. In 61%, there is pain-free effect, which is lasting for less than 6 months. In 27%, we find is the pain-free effect is lasting for 12 months. 4% we have post-operative infection. 40% the patient has suffered some pain ranging from burning sensation. Coming to the alcohol blockade, this is direct dependence on the alcohol and the direct deposition of the alcohol into the affected nerve. There is chemical ablation of the nerve, and then it seeps into the adjacent tissue and causes necrosis. 0.5 to 1 ml absorbed alcohol, absolute alcohol is sent into the area. So care is taken so that no intravascular injection is done or subcutaneous tissue is not involved, like it is not injected directly into the subcutaneous tissue. There may be chemical neurolysis with glycerol, phenol or mixture of lignocaine with streptomycin, and high concentration of tetracaine can be done. So I have tried to briefly talk about the various aspects of TGN. I hope it helps you in understanding it as well as making short notes. Thank you so much.